Good morning, everybody. Thank you for joining us today for this press briefing. My name is Ifeyinwa Osunkwo. I am a lifespan hematologist at the Levine Cancer Institute, which is a vertically integrated healthcare systems cancer center that supports patients in the Southeast USA. We're one of the fastest growing cancer centers in that region, and currently about 1 in 3 individuals living with sickle cell disease lives in the Southeast. One of the missions of Levine is to help increase access to care for people living with sickle cell disease, and that's why we're here today. So today, we are welcoming you to the press briefing of the 60th American Society of Hematology annual meeting and exposition. The title of this session is Improving Sickle Cell Disease Outcomes in the US and Africa. Before we begin, please mute your phones. Before we begin, please mute your phones and turn off the noise on your camera clicker so you don't distract the speakers when they're speaking. The studies presented today reflect advances in our understanding of sickle cell disease care and management. People with sickle cell disease live with an abnormal inherited hemoglobin. The hemoglobin molecule helps you carry oxygen from the lungs to different parts of your body. When this hemoglobin is abnormal, it creates a donut-shaped, when it's normal, it creates a donut-shaped cell. When it's abnormal, like in sickle cell disease, the cells are sickle-shaped, and they do not carry oxygen to parts of the body, leading to difficulties in terms of blood circulation, blood vessel damage, and damage to different organs, including the brain, the lungs, the heart, and it can lead to early death. In sickle cell disease, we know that access to care is a big priority, and ASH has committed themselves to increasing access to care by launching in 2016 an initiative that is multi-pronged to address the burden of disease in the Southeast. Although there are very few treatments for sickle cell disease, we know that if we accelerate research and development of new drugs, we can improve the lives of these patients. Taken together, today's abstract results have demonstrated that we can enhance the clinical ability to offer a wide variety of treatment options to our patients with sickle cell disease and improve lives not just in the US, but also across the globe. Dr. Mitchell Cairo of the New York Medical College in Valhalla, New York, will present results of a first-in-human trial of a novel approach of partial match or haploidentical stem cell transplant for sickle cell disease. Unlike traditional stem cell transplant that requires a full sibling or a full brother or sister, Dr. Cairo's method has the potential to allow everybody to have a transplant because everybody has a parent who brought them into this world. With a median follow-up of 3 years, 90% of patients receiving this CD34-enriched stem cells from a partial match donor will remain alive and symptom-free by the results that we will hear from Dr. Cairo. In some instances, they also found out that their cognitive processing speed, so their ability to learn, retain, and remember information also increased. Details of this can be found in abstract number 162. Our second presenter, Dr. Erika Ersick of Dana-Farber Cancer Center in Boston, will present the results of a first-in-human pilot study of a new autologous gene therapy that could potentially cure sickle cell disease. This method delivers a lentiviral vector and targets the BCL11A protein to induce the production of fetal hemoglobin. This fetal hemoglobin will accept and release oxygen at a lower oxygen tension and allows your cells to live longer before they hemolyze. This was performed in a patient in Boston who, with 6 months of follow-up, has shown no sickle cell-associated symptoms. Details can be found in abstract 1023. Our next speaker, Dr. Leon Shilolo of the Centre Hospitalier Monkole in Kinshasa of the Democratic Republic of Congo, will present one of the largest clinical trials to analyze the safety and efficacy of hydroxyurea in treating sickle cell anemia, a severe form of sickle cell disease in children across sub-Saharan Africa. For those who do not know, Africa has the highest burden of sickle cell disease in the world. After 2.5 years of treatment, over 600 children were enrolled and adhered to the study procedures, and above 90% of these patients experienced less pain and anemia with fewer episodes of malaria and other infections. And there were also lower rates of transfusions and death compared to rates that they experienced before they went on study. Details of this can be found in abstract number 3. Finally, Dr. Olademije Akimboro from Boston University School of Medicine will present data of 15 years showing that while the rate of admissions for sickle cell disease in adults has increased over a period of time, in-hospital mortality has not increased and has remained steady. For comparison, the rates of opioid-related deaths in the broader U.S. Population has increased by 350% during the same time period. Results of this can be found in abstract number 315. We hope that today's abstract will begin to share with you that it's really exciting and important to invest in sickle cell disease research, and that it used to be a disease of childhood where they died before their 5th birthday, but with these advances, we can encourage and provide care for these patients over the course of their life to increase longevity and increase quality of life, not just in the US, but around the globe. After all the presentations, we're going to open up the floor to questions. To ensure we have plenty of time, please save your questions for after the last speaker has presented. Dr. Carroll will be our first presenter. Dr. Carroll, I invite you to begin to discuss your topic. Thank you.
Good morning. I'd like to thank the ASH leadership for selecting our abstract for this press discussion. It's a pleasure to be up here with Iffy and my other colleagues. On behalf of the multidisciplinary, multi-institutional group, I'm going to present the results of our haploidentical transplant protocol and focus predominantly on quality of life and neurocognitive changes besides transplant outcome. So as a brief background, patients with sickle cell disease have a high risk of developing central nervous system complications. As you can see here in this cartoon, patients develop cognitive defects. Some patients have what we call a silent infarct, which means that they had a mini stroke but didn't realize they had it until it was picked up on a brain imaging. They may have overt strokes, or they may have intracranial hemorrhage and other complications, and some of these actually lead to death. More importantly, work that was performed looking at IQ as an endpoint. You can see here that in patients who have had silent strokes or overt strokes have a significantly lower IQ than normal sibling controls who don't have sickle cell disease. And even patients who have sickle cell disease but have not had any central nervous events have a significant decrease in their IQ. It's a little bit complicated slide, but this is looking at a recent publication on the left here of neural processing speed, and this is in comparison to normal patients versus those that have either had an overt or non-overt stroke. So significant decrease in neural processing speed. And on this side is looking at the quality of life. And you can see here that this being close to 100% quality of life, patients at various ages have a significant decrease of quality of life, averaging about 40 to 60% of their normal controls. So very briefly, a complicated protocol. We developed a consortium of several centers and several core centers that embarked on this myeloimmunoablative conditioning, which consisted of giving immunosuppressive therapy for about 5 weeks, consisting of hydroxyurea and azathioprine, and then a more classical conditioning consisting of busulfan, cyclophosphamide, thiotepa, rabbit, antithymocyte globulin, and a 1 dose of total lymphoid irradiation. In this context, as if he mentioned, we used patients who did not have a sibling that was a full HLA match or full tissue donor. We chose parents, and we processed the parents' peripheral blood stem cells using a device called a Clinimax, where we could select out and enrich cells that expressed a marker that was highly prevalent in early bone marrow cells. But then what was unique about this protocol is we added back a fixed amount of immune cells to promote engraftment and to promote immune recovery quickly, but not enough to cause the complication called graft versus host disease. For the purposes of today's discussion, we did a full battery of neurocognitive testing at baseline, at 1 year and 2 years, and we did a full battery of health-related quality of life testing, looking at emotional, physical, and a number of other parameters, and we tested both the patients and their age specific, as we tested one parental involved in the family, so we had a parent as well as a child's responses. So while the details will be given later today at 1:15 in room 24B, this is looking at the overall outcome, event-free survival and overall survival, reaching a 1-year overall survival of 90%. And to focus on the long-term follow-up, this is looking at intellectual functioning, processing speed, and memory. And you can see here for the processing speed, there was a significant enhancement in the processing at 2 years compared to what it was at baseline. From a health-related quality of life, you can see here, as expected, after 45 days or 100 days after the transplant, there's a significant reduction in the quality of life based on the transplant morbidities that one experiences with transplant. But by the end of 2 years, their quality of life, both emotional and physical findings, are almost approaching 100%, and they're significantly better from the decrease that they started with. And in summary, these are a number of the patients that are survivors of the transplant protocol, and basically we have now a 3-year follow-up of this study, and there are no patients that have any signs of sickle cell disease, sickle symptoms, and they're all off immunosuppressive therapy, and they're actually all off all drugs. And for more detail about this follow-up, I encourage you to come to the 1:15 presentation. Thank you.
Thank you, Dr. Kyer. We're going to have Erica Essick talk about flipping the switch.
Thank you very much for the opportunity to be here to share initial data from the Boston Children's Hospital sickle cell gene therapy study. It's quite an honor to join this group of dedicated sickle cell researchers. Oops, sorry. Okay, thanks. Some disclosures for Dr. Williams and myself are here. This slide depicts, as background, genetic expression at the beta-globin locus over time. So on the left is, during fetal life, high levels of gamma globin are expressed. And when combined with alpha globin, they form fetal hemoglobin, or hemoglobin F, which is a healthy, non-sickling type of hemoglobin. However, after birth, a natural switch occurs, shifting expression from gamma globin to beta globin, which is where problems begin for sickle cell patients because the mutation that causes sickle cell disease is located in the beta globin gene. Instead of making normal adult beta globin, these patients make hemoglobin S, or sickle hemoglobin, which causes all of the downstream complications in sickle cell disease. Our therapeutic goal is to use gene therapy to provide a set of genetic instructions to the red blood cell precursors to flip the switch back to producing high levels of fetal hemoglobin and low levels of sickle hemoglobin. But how is this switch controlled? About a decade ago, Stuart Orkin and Vijay Sankaran and others described BCL11A as a strong repressor of fetal hemoglobin. So our approach is to knock down BCL11A via RNA interference to induce gamma globin expression. A potential advantage of this approach over the gene addition strategy of gene therapy is that we can harness the physiologic switch machinery that exists in the cell to simultaneously increase fetal hemoglobin and decrease sickle hemoglobin. To achieve that goal, David Williams and Christian Brendel and others designed a lentiviral vector that contains an shRNA that targets and decreases expression of BCL11A. Importantly, this vector contains a novel construct in which the shRNA is embedded within an endogenous microRNA structure. We call this combination structure a Schmier vector. The purpose of that structure is to allow the vector to be expressed only in the red blood cell lineage and to avoid off-target toxicity that would occur if we decreased expression of BCL11A in other cell types, such as B cells or hematopoietic stem cells. This Schmier BCL11A vector is what we're testing in our clinical study. The first step for patients in our study is to have hematopoietic stem cells, or HSCs, collected via peripheral stem cell mobilization, using plerixafor as a stem cell mobilizing agent. The cells are then transferred to a cell processing facility where blood stem cells are selected, transduced with our BCL11A vector, and cryopreserved. When the product undergoes testing and meets all release criteria, the patient is admitted to the transplant unit to receive myeloablative conditioning with busulfan before infusion of the gene-modified cells. During follow-up, which is on this study for 2 years and then a long-term follow-up, patients are followed closely for safety outcomes and also for lab outcomes including BCL11A levels, fetal hemoglobin levels, and of course any sign of sickle cell symptoms. Our study is a single-center pilot and feasibility study with a total of 7 enrolled patients planned. We are enrolling patients in 3 staggered age cohorts, starting with adults before moving on to younger patients. So far, we have 4 subjects enrolled. All 4 of those subjects have undergone peripheral stem cell mobilization and apheresis. Manufacturing has completed in 3 of the patients, and the 4th is well underway. And we have treated 1 patient by infusing gene-modified cells with a follow-up of over 6 months. Characteristics of the manufactured menocytal products are shown here. The vector copy number, or VCN, ranges from 3.3 to 5 copies per cell, which suggests excellent transduction efficiency. The cell dose in CD34 cells times 10 to the 6 per kilo ranges from 3.3 to 6.7 in these products. And in all of the products, over 95% of the cells are transduced. Subject BCL002, whose product is described in the middle column, was infused in May 2018. The autologous transplant course for this patient was uncomplicated. Neutrophil engraftment occurred on day 22. Adverse events were all consistent with myeloablative conditioning, and no adverse events were associated with the medicinal product. On the left shows types of hemoglobin over time in this subject. In the blue line is hemoglobin A, or normal adult hemoglobin, which initially was high because of the prior transfused blood and decreased to 0% by 4 months after gene transfer. Hemoglobin F, depicted in the red line, rose substantially after gene therapy and has remained in the 25 to 28% range since month 3 after gene therapy. But just as important as the total amount of fetal hemoglobin is how that fetal hemoglobin is distributed. We can assess this by looking at something called F cells. F cells are cells that produce fetal hemoglobin in a measurable level. And on the right graph, you can see that our patient is producing and maintaining a very high level of F cells. So this suggests that his fetal hemoglobin is distributed broadly, protecting a large proportion of cells against sickling. Finally, our subject thus far has experienced reversal of sickle cell phenotype. There's been no pain, respiratory events, or neurologic events. The patient is not anemic with a normal total hemoglobin of 11 grams per deciliter at 6 months and laboratory evidence of much decreased hemolysis with a low reticulocyte count and LDH. There have been no transfusions required since engraftment. The photos below show peripheral blood smears from our patient. Before gene therapy on the left, you can see quite a few irreversibly sickled cells, which are the small sickle-shaped narrow cells. 6 months after gene therapy, there are no visible sickled cells on the peripheral blood smear. In conclusion, we've shown effective collection, gene modification, and clinical grade manufacturing of a BCL11A targeted stem cell product in 3 patients. Early data on engraftment in 1 patient demonstrates the first use of this Schmier construct vector with good short-term safety profile. Validation of BCL11A as an effective target for fetal hemoglobin induction in humans, as evidenced by high level of fetal hemoglobin per F cell and high numbers of F cells in circulation, and early mitigation of some of the cellular phenotypes of sickle cell disease. Thanks.
Thank you very much, Ms. Erica. So we're going to have Dr. Cellular talk about the REACH study.
Thanks for giving me this opportunity to present you the REACH study. REACH study is a phase 1/2 open-label trial of Hydroxyurea conducted at 4 clinical sites in sub-Saharan Africa, in Angola, DRC, Kenya, and Uganda. The goal was treating 600 children between age 1 to 10 years. The study was conducted through the Cincinnati Children's Hospital. To enhance safety, we used Simon two-stage design, and the RedCap website provided online dosing calculators. The Hydroxyurea capsule were donated by mid-scale, sorry, the previous slide. The Hydroxyurea capsule were donated by Bristol Myers Squibb. Patient began Hydroxyurea at 15 to 20 milligrams per kilo per day as a single oral dose. After 6 months of fixed dose, we increased the dose. Sorry. I just have a problem with my, I would like to help me there. Sorry. We increased the dose. We increased the dose after 6 months to the dose was by dose escalation to a maximum tolerated dose, MTD, increasing the dose by 2.5 milligrams per kilo per day every 2 months. The MTD was defined as mild marrow suppression without toxic effects, primarily neutrophils, but also reticulocytes and platelets. The main study objectives were feasibility, safety, and benefits. For feasibility, we focus on enrollment study retention and adherence to the protocol and the medication schedule. For safety, we focus on dose-limiting laboratory toxicities, which serve as the primary safety endpoint. These were recorded of both dose and after escalation to MTD. We also recorded the rate and severity of infections, especially malaria. Laboratory benefits included changes in hemoglobin and fetal hemoglobin. Clinical benefits included Sickle-related events like pain and acute chest syndrome, plus important clinical events like transfusion and survival. 635 children were consented in the REACH trial. During the 2-month screening period, there were 29 children who withdrew for various reasons, including 4 deaths. 606 children were initially treated, and 600 received 3 months of treatment, which was marked the primary safety endpoint. Regarding retention, 89% of scheduled variants were completed, and 84% of the children remained in the study at 3 years. Regarding adherence, families were asked at each clinic visit, and 80% of these assessments recorded no missed dose. Those limiting toxicities were the key safety parameter defined here. Note the very low hemoglobin threshold, which was appropriate in the African setting where many children have severe anemia. In the first stage of enrollment, 53 children at each site were studied and confirmed safety of our starting dose. In the second stage of enrollment, the first 133 participants at each site were studied, and only 5% of the children had a dose-limiting toxicities, well below the expected 30% threshold. Laboratory benefits of hydroxyurea treatment are shown on this slide. Compared to baseline values, 3 parameters expected to increase did so: hemoglobin, MCV, and fetal hemoglobin. The average hemoglobin rose by 1 gram per deciliter, and average fetal hemoglobin increased to over 20%. Similarly, 3 parameters expected to decrease did so: neutrophils, reticulocytes, and platelets, but without toxicity. These laboratory benefits continue through months 24 and 36 and beyond. The rates of specific clinical events are shown comparing the 2-month screening period with subsequent 6-month treatment intervals. Sickle cell-related events decreased, especially vaso-occlusive pain and acute chest syndrome. These low rates were sustained through month 36. Additional clinical benefits were observed for the rate of both malaria and non-malaria infections, significantly decreasing while on hydroxyurea treatment. The rate of transfusion was lower on treatment, and most importantly, the death rate decreased on hydroxyurea. In conclusion, our study documents that hydroxyurea is feasible, safe, and effective treatment for African children with sickle cell anemia. Hydroxyurea is associated with reduced rates of malaria and other infections, leading to improved survival. Based on our data, we believe that wider access to hydroxyurea for sickle cell anemia has the potential to save millions of lives in Africa. Thank you.
Thank you, Dr. Shisholo. We're going to have Dr. Kimbrough discuss opioid use in inpatient and sickle cell mortality.
Thanks to the ASH Abstracts Review Committee for selecting our abstract for oral presentation and also for invitation to this press conference. So we looked at hospitalization rates as well as opioid inpatient-related mortality in the general population as well as the sickle cell disease, as well as among individuals with sickle cell disease hospitalized in the United States over a 16-year period from 1998 to the year 2013. And just as a background to our study, I think an earlier study that looked at hospitalization rates through the year 2008 had reported that the hospitalization rates in those with sickle cell disease had been stable over that 10-year period following the FDA approval of hydroxyurea in the United States. However, since the year 2000, the opioid epidemic has been described in the United States, describing the marked increase in rates of in the rates of deaths as well as toxicities related to opioid use in the United States. So we looked at an inpatient database, the National Inpatient Sample, which captures roughly 20% of all hospitalizations in the US, and looked at deaths related to opioid use, specifically in the sickle cell disease population as well as the general population. And the first chart here shows similar results with the prior study that had been reported in 2008, which suggests that overall, over the 16-year period, in the overall sickle cell disease population, the rates of hospitalization were stable. There was a slight decrease in rates through the years 2002, 2003, but if you exclude the rates for those years, you could pretty much draw a straight line from 1998 to 2013. So summarily from this slide, it appears that the rates were stable. However, what's not obvious on this slide becomes more obvious when we looked at the rates of hospitalization by age. And we found out that among those who were aged, among those who were aged 18 to 44 years, the rates increased by 3.7%, from about 43 per 100,000 to 71 per 100,000 persons in 2012 and 2013. And the steepest rates were found among those who were aged 65 years and above. The rates actually doubled from 2.7 per 100,000 to 5.4 per 100,000 in the year 2013. And then when we looked at the rates of hospitalization by length of stay, we examined this to see if the rates of hospitalization for short stays might have, one way or the other, influenced the rates of hospitalization we saw in the overall population, as well as the hospitalization by age groups. And what we found out was that there was some increase in the rates of short stays, that's hospitalization rates for those who were hospitalized for less than 1 day. But this was mild, and the chart on the left, the inserts, demonstrates that there was a significant rise in the rates of short stay hospitalizations. However, most hospitalizations the rates were driven by the long stay hospitalizations, defined as those greater than 1 day, for which we found out that the rates were variable and overall did not demonstrate that there was any change in long stay hospitalization rates. And then looking at opioid-related hospitalizations in patients with sickle cell disease as well as the general population, what we found out was that the rates were pretty much they were stable in the sickle cell disease population, save for the drop in 2002, which we could not quite account for. And the rates in the sickle cell disease population was also similar with the rates that we see for the general population. You see that the curves pretty much are stable if you exclude the rates for 2002 in the sickle cell disease population. So suggesting that the rates in the sickle cell disease population was stable compared with the US population. However, when we look at the general inpatient mortality pattern amongst patients with sickle cell disease from the year 1998 through the year 2013, we don't see any significant change in hospitalization rates. And the p-value for this was 0.59, suggesting that the rates were stable through the study period. And this chart here compares the rates of opioid-related deaths in the US population versus the sickle cell disease population. And the chart on the left just demonstrates that in the general US population, there's been a steep rise in opioid-related deaths those are deaths related to opioid overdoses in the United States, the general population. And the rates increased by about 350% over the entire study period, rising by about 8% annually from 1998 to 2013 in the general US population. However, in the sickle cell disease population, opioid-related deaths in the inpatient setting was almost non-existent, and that we see on the left. And actually, in that population, over the 16-year period, there were only 9 deaths that were reported, suggesting that opioid-related deaths in the inpatient setting among those with sickle cell disease is almost a never event. So what were the conclusions from our study? We find out that opioid hospitalization rates appear to be rising, at least among subgroups, among adult subpopulations with sickle cell disease. Those are those aged 18 to 44 and those who are elderly above 65. And this begs the questions, why? While we didn't exactly examine that in this study, prior literature suggests that this might be related to fragmentation of care in the adult sickle cell disease population, as well as an increase in age-related pain-related medical comorbidities. And the implication for this is that we need further patient-level analysis to try and identify adults with sickle cell disease who might be driving the these trends, particularly those aged 18 to 44, who account for the majority of hospitalizations in those with sickle cell disease overall. Then we also found out that opioid-related hospitalizations are stable in the sickle cell disease population compared with the US general population. And finally, we found out that opioid-related deaths in the inpatient setting are almost never seen with sickle cell disease patients, unlike the general population in whom we've seen a steep rise in opioid-related deaths in the inpatient setting. So overall, this suggests that the present patterns of use of opioids in patients with sickle cell disease, this overall, it appears that this is safe, and opioids should not be withheld from those with sickle cell disease when indicated, provided that we continue the present risk mitigation strategies. Thank you.
Thank you very much. We're going to open up the floor to questions. If you raise your hand, yes, sir. Yeah. Go ahead.
If you all please recognize the organization you're with as well.
Thanks. Hi, Neil Osterweil of Family Practice News. A question for Dr. Ezrick. So I know it's early days yet, but do you think that this effect that you see is going to be durable? We've heard about other efforts with using, let's say, CRISPR to edit the genome to mimic the fetal hemoglobin mutation, and I wonder if you think that you're going to be getting similar results.
Sorry, thanks for the question. So durability is one of the most important things that we're assessing in this study, of course. We're hopeful and optimistic that the effect will be durable. It's encouraging that there's been essentially a plateau in the levels at this point. It's too early to compare to other genome editing techniques which haven't yet been tested in the hemoglobinopathy setting, but durability is an excellent question that we'll be looking at closely.
And just about the schmear, about your schmear RNA, I mean, is that specifically referring to this the short hairpin RNA?
It's referring to this construct that embeds the shRNA within an endogenous microRNA.
And inspired by bagels and cream cheese?
What's that? Yeah.
Name? Okay.
Unrelated to bagels.
Yeah. A question for Dr. Cairo. Thanks for your presentation. A couple of things. Can you maybe better describe the two cases of GVHD that you saw in the study? And then also, one thing when you talk to folks like Dr. Ezrick and others who are doing gene therapies, they always talk about the fact that, for stem cell transplants, they're very difficult to find matched donors. It seems like your approach might increase that. So I was wondering how you see sort of your approach relative to kind of a lot of the gene therapy approaches for sickle cell that are being developed.
Thank you for the question. So yes, we had one patient who developed acute GVHD, so the probability of acute GVHD was 6.2%, and one patient developed chronic GVHD with a cumulative incidence about 6.7%, which is actually lower than the risk of GVHD when you use HLA-matched sibling donors. So it's not zero. So we continue to look at ways that we can try to reduce that number to zero. In the gene therapy world, we welcome the innovations that are going on, particularly the one from Boston Children's this morning, as well as others. So, I think they're kind of in parallel. So the here and now, of course, is that with transplant we can get 90% curative rates, but I think we'd all be happy if X number of years from now we can do this with less toxic therapy, less long-term complications. I mean, there are some things that are useful in terms of what we have learned about mobilization of sickle cell donors and how we can ablate the marrow so that rejection isn't a problem. These are things that can be helpful to the gene editing people. So I do think there's going to be some crosstalk, but obviously we want to look at all options that can ultimately result in the curative therapy of this horrific disease.
Next question. Yes, ma'am.
Annette Brindle from BioWorld. I've got a question for Dr. Ezrick, actually. So, is it correct that you are repressing a repressor with your approach? And if that is correct, would it be possible then to develop RNAi approaches, which would not be curative, of course, but might be a lot cheaper and have a broader reach, ultimately? And is anybody thinking about that at all, if it is theoretically possible?
So thanks for the question. So first of all, you're correct. It is repressing a repressor, or you could sort of think of it as de-repressing the expression of fetal hemoglobin. Folks are looking into the possibility of, could there potentially be a small molecule to target BCL11A instead of requiring gene therapy, but nothing yet ready for translation.
Next question.
Yes, question to the Professor Chilolo. What is the availability of hydroxyurea today in African countries? And what about the future? What is the possibility to scale it up and lower the price?
Can you repeat that question, the second piece?
Yes, about the future. What is the possibility to lower the price of hydroxyurea with the generic manufacturers, for example?
So if I can translate, it's what is the availability of hydroxyurea in Africa, and what is the potential in the future to make it cheaper in Africa?
For the questions, but I'm not focused on that aspect of the future of the use of Hydroxyurea in Africa. It will depend probably of the possibilities to get these drug in a wide range in many of the African countries. That depends on the pharmaceutical industries and the availability to get it in Africa. Our experience will focus on the safety, feasibility, and benefits of these drugs in young children. But I hope that it will be available in the next years for many of the African sickle cell anemia patients.
So to piggyback on that, there are companies in Africa that are manufacturing hydroxyurea, but it's not cheap. And it's probably cheap in American standards, but not cheap for African standards. So it will be part of what the efforts will be going forward and how to make it more available to a large variety of patients in the continent. Next question. Yes, sir.
Andrew Bowser with Hematology News. I also have a question about the REACH trial. One of the key conclusions is that hydroxyurea was associated with a reduced rate of malaria, among other infections. There was a study about a year ago called No REACH that was published that I believe the focus was to see if there was any risk of an increase in malaria in patients treated with hydroxyurea in Africa. And the results of that study showed there was no difference in this randomized trial between patients who received hydroxyurea and patients who didn't with regard to outcomes in malaria. So I'm wondering, why would there be a reduction in malaria in this trial with the introduction of hydroxyurea, or is that difference substantial enough to say, or is there a significant difference, or what would be the rationale for saying that there's a lower incidence of malaria with the introduction of hydroxyurea?
Yeah, that's a great question, and I think that I can first say that it's a real event that we observed, the reduction of malaria and non-malaria infection in all our patients who were submitted to hydroxyurea. One of the reasons that we can say is it's why the children were well followed up than the other groups without that were not in the trial. But it's not enough. Previous study made in Uganda, where malaria is present, has not demonstrated increasing risk of malaria in these patients who were submitted to hydroxyurea. But we don't know the mechanism of the cause of this would be due to the high level of fetal hemoglobin.
Okay. That's interesting because in your abstract you say the purpose of this study was to provide some data specifically for African countries of the use of hydroxyurea, which has been around for many decades. What is the bottom line? How does this data compare, or what has this added? What are you learning that you didn't know before now that you have the data in this particular population?
Yeah, but these data show that it's possible to use hydroxyurea in these specific populations without increasing risk of malaria.
Next question.
Michelle Cortez with Bloomberg. I'm wondering, I have a question as well about the REACH trial. Well, actually, I'm wondering the extent to which hydroxyurea is used currently in Africa, and if there are any programs to encourage its use, to both of you. And then also, as a complete aside, on the gene therapy, how do you spell schmear in this context?
So the question was, are there efforts right now to expand hydroxyurea use in Africa, and how much is hydroxyurea used in Africa currently?
How much is used in Africa?
Currently in sickle cell disease?
Very few. I can say very few because hydroxyurea is not available in many of the African countries.
And initiatives to increase hydroxyurea are going to stem from the results of these studies and continued advocacy with, hopefully, the assistance with ASH. And Dr. Esrick's question was, how do you spell schmear?
Small s, small h, small m, small I, big R.
I have a question for Dr. Chilolo. Did you notice any difference in the results if you break the results down by country? So between Kenya, DR, and Uganda, would you notice any differences across it per country?
Not so great differences according to the median data we observe in both 4 countries. But we observe, for example, that the Ugandese children has a high level of MTD dose compared to the children who are living in Angola. Mm-hmm. This was probably due to the difference of BMI in the two groups. In the east part, it seems to us that they are well nourished compared to the west part of Africa in DRC and in Angola. Globally, the results are almost the same.
And is there any difference in malaria rates among these countries?
In the east part, no, that depends because Uganda is a large country. In some areas, the prevalence of malaria is less than in the capital. And in DRC, we have a high prevalence of malaria in the west part compared to the east part. I don't think, yes, I can say that in the previous NOAM study, the prevalence of malaria was low comparing to the studies, to our REACH study in Kinshasa and Rwanda, where we have a high prevalence of malaria.
Okay. And I think that's going to influence how we use hydroxyurea and the things you need to worry about, because there is not a uniformity of any of these African countries in terms of malaria rates, even during the same times of the year. Next question, I think.
Annette Brindle from BioWorld, a question for Dr. Cairo. Can you give us sort of a big picture overview of haploidentical stem cell transplants? And I know that they're a new method in being tried in a variety of indications, so how are they doing these days compared to, a fully matched transplant? And are you, is part of what you're saying that it works better in sickle cell disease than in some of the other indications, or are you saying it is working well in sickle cell disease as it does in other indications where it's being tried?
Yeah, 2 great questions, thank you. So haploidentical transplant is where you're using pretty much a half match between the donor and the recipient. It's gone through several phases, actually. So in the early 80s and late 70s when it was tried, there's a lot of rejection and a lot of what we call graft versus host disease, where the donor is reacting against the recipient, and it kind of fell out of favor. And then in the cancer world, it kind of was revisited again with now methods of trying to avoid, in particular, the graft rejection and the graft versus host disease with various different approaches. The results in the cancer world are variable because it's going to depend on the type of cancer that they have and what disease state and when the transplant's being done. And there are really two big buckets in that world. One is similar to what we're doing, is some form of cellular engineering of the graft before it goes into the patient. And the other is using a drug called cyclophosphamide after you receive the haploidentical transplant. That latter approach was tried in patients with sickle cell disease early on, and the result was that there was a lot of graft failure, about 40 to 45%. In the context of this study, why we ended up going this route was that we had already proven, as others have, that matched sibling donors work quite well, and one can use a lot less of the conditioning when one's using a matched sibling donor. But the other donor sources, which were using an unrelated adult donor or an unrelated cord blood donor, there were a number of issues that developed either due to graft failure or due to excessive chronic graft versus host disease. So while those are still being done under experimental protocols, the results haven't been as robust as one wanted. So what the haploidentical approach opens up is, if he mentioned earlier, is the potential that everybody has a donor. Could be a sister or brother that's a mismatch, or in our case, a parental donor. And so the approach that we took here was a cellular engineering approach, which was to try to basically give the cells that are important for engraftment and just a fixed number of immune cells that would allow the engraftment to take place, allow more rapid immune recovery, but not enough to cause a high incidence of graft versus host disease. So although the numbers are small and we're into our second study now, and this is funded by the FDA, what the early results show is that the results are almost as good as using a matched sibling donor. Not that we would want to use a matched sibling donor first, and opens up the possibility that everyone could possibly have a donor. And then the second, which is the focus of today's presentation, is that not just that the transplant is working, but that actually the long-term effects, which we'd expect to get worse over time, are actually stabilizing or getting better. And so what we want to see at the end of the day is that not just the transplant's working, but the patient's going back and resuming normal lives.
This is for Dr. Kimbrough. So you talked about the fact that the opioid-related deaths have increased in the U.S. over the past 15 years at a rate that is astronomical. And you talked about in the hospital, sickle cell patients are not dying from opioid-related deaths. Did you compare, what was your definition of opioid-related deaths for sickle cell disease and for the general population? How was that defined?
Okay, so what we did was we looked at the admission diagnosis. That's on the discharge summary. Okay. So we defined opioid-related deaths as patients who died in the hospital for whom the primary reason of admission was an opioid overdose. Okay. So the opioid-related deaths were not related to opioid use in the hospital, but these were reflecting patients coming in from the outpatient setting with opioid-related overdoses and toxicities.
So a follow-up to that is, what do we have in terms of the data for the general population in terms of they don't come to the hospital, but they die outside of the hospital from opioid-related deaths? And do we have data for that in sickle cell disease to compare?
So if I understand the question is looking at so we'd like to know what the outpatient mortality pattern is for sickle cell disease patients. So we didn't examine that in this study, but an earlier study that was reported about 3-4 years ago that looked at overall opioid-related deaths had suggested that actually in the sickle cell disease population, overall inpatient, outpatient. They just looked using a CDC database. It appeared that opioid-related deaths in the sickle cell disease population was lower than opioid-related deaths from other pain-related comorbidities like fibromyalgia, low back pain, as well as, I think, just headaches, for which opioids are often used, rather inappropriately.
Why do you think that is? Because do you think it's disease-specific protection, or do you think it's coding and documentation bias?
So that's, and that's an excellent question, and it's possible that this may reflect, documentation bias, just because we are using an administrative database, and there could be errors of documentation. However, I think a prior study has suggested that in the sickle cell disease population, I think well over 80% of hospitalizations are well captured as hospitalizations that are due to sickle cell disease patients. So that's with regards to hospitalization in those with sickle cell disease. And then with regards to documentation for opioid-related toxicities, while it's also possible that there could be some documentation bias, I think it's inconceivable to see how this might differ for those with sickle cell disease admitted to the hospital, as well as those admitted for, those without sickle cell disease admitted to the hospital. So, I mean, in other words, even though we might have documentation bias related to opioid-related deaths, we don't think that would be any different for sickle cell disease population versus the general population, so that shouldn't bias our study findings.
And so I want to segue Dr. Cairo. So he mentioned that the admission rates for the 18 to 40-year-old patients have dramatically gone up. How do you think your therapies and Dr. Ersich's therapies should impact that demographic? They're living longer now, and they're not doing so well. So thinking of the future, what would you hope to see in terms of how to address that increased acute care utilization, increased morbidity in the older patient population? Dr. Cairo and then Dr. Ersich.
Now, based on this original study, have launched a second trial now where we're incorporating, instead of the older age being 21, we've now increased it to age 35. Excellent. One of the things that we're using in this new study is a drug called defibrotide that is approved to treat veno-occlusive disease, which we think will be a risky complication in the older sickle cell population, so that's now being given prophylactically. So we are now addressing this need in the older population, knowing that they're going to have a higher degree of morbidity, potentially higher mortality, but feel that we should now test this population to see if we can cure this group as well.
Thank you. Dr. Ersich?
Our study is open up to age 40, and we've seen a great deal of interest in older meaning in their 30s, adults. And I think, you and I were talking before the session about how historically transplanted sickle cell disease has really been considered only a treatment for young patients, but that's changing, and I think that as we get more experience both in allotransplant and in autologous genetic therapies in older adults, especially with close collaboration between pediatric programs and adult programs, that this will be an option for more older adults.
Very good. Any questions from the audience? Dr. Shilolo, you mentioned that you had a high retention rate, a high enrollment rate. Why do you think that happened? What is it about this study in this continent that was a surprise? Because I think there's a lot of thought that, it's going to be very hard to recruit patients in Africa because of logistics. Can you comment on what you found?
I think that one of the things it was a surprise, it was the feasibility. Because most of the different partners said that it was not possible to make such trial in an African country where we have instability, no energy supplies, and so on. It was a very real challenge. And the second unexpected result is the reducing of the malaria events and infections. It was surprising.
Why do you think people were so engaged in enrolling and staying on the study for 3 years. It's extremely difficult to keep a patient with sickle cell disease on a clinical trial for 6 months, and you did it for 3 years. What do you attribute that success to?
Yeah, I think that it was due to the good organization and the good relationship between the families and health workers. We have nurses who gave the personal telephone to the families. We help the families for the transport. Mm-hmm. We give them free drugs, and the monitoring was free, and so on. That was, for me, it was one of the reasons of the good enrollment and the stability of the patients to continue in this trial for 3 years. They are continuing till today.
Awesome. So as we wrap up this session, thank you everybody who attended. I want to give each of the speakers one sentence. If you want to give people a take-home message about your study, what would that be? Starting with Dr. Kimbalo.
So the take-home is that it appears that for individuals with sickle cell disease population, current outpatient opioid prescription patterns, appears safe and does not translate into mortality in the inpatient setting. Okay, Dr. Kam.
Yes, the use of hydroxyurea is possible in the African context, and we need to enlarge the use of it in many of those patients.
Thank you. Dr. Ersak?
Targeting BCL11A using gene therapy looks to be a promising approach to increase fetal hemoglobin and reverse the findings of sickle cell.
And Dr. Cairo?
I think patients who have high-risk features of sickle cell disease now potentially have an allogeneic donor in their family if they're interested in pursuing allogeneic transplant for curative therapy.
Excellent. Thank you very much, everybody, and this concludes our session.